Good afternoon. My name is Matthew Clay, and I'm with JBS International. Thank you for joining us for today's webinar, The Role of Opioid Treatment Programs in Integrated Care. Before we begin, I'd like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. If you have any comments or questions, please submit them at any time by using the Q&A window. To open your Q&A window, please click on the Q&A icon located in the bottom center of your Zoom window. Closed captioning is also available. To turn on closed captioning, click the CC icon located at the bottom of your screen. If you experience any technical issues during this webinar, please message us using the chat feature, which is located at the bottom center of your screen, or you can email us at samhsastatA@jbsinternational.com. Lastly, this is a recorded event, and your participation grants consent to be recorded. The recorded webinar and PowerPoint slides will be available and sent to participants at a later date. At this time, I will introduce our speakers for today's webinar. Dr. Ingvild Olsen serves as the Director of the Center for Substance Abuse Treatment at SAMHSA. She has a long history of working with the addiction treatment field to expand access to care and enhance quality. Dr. Olsen began her career as the Medical Director for the Johns Hopkins Outpatient Substance Use Treatment Services, while a full-time assistant professor in the Department of Medicine at the Johns Hopkins School of Medicine. She subsequently served as the Deputy Health Officer for Maryland's Harford County Health Department, where she led a modernization of publicly funded substance use treatment services in collaboration with state and local partners. She next served as the Vice President of Clinical Affairs for the Baltimore Substance Abuse Systems, then the Local Addiction Authority for Baltimore City. Dr. Olsen has also served as a medical consultant to the Maryland Behavioral Health Administration, as a clinical expert to the Maryland Addiction Consultation Service at the University of Maryland School of Medicine, and as an advisor on addiction interviews to the Baltimore City Health Department. From 2011 to 2021, she served as medical director for the Institutes for Behavioral Resources, REACH Health Services, a comprehensive outpatient substance use disorder treatment program in Baltimore City. Next, we have Dr. Aaron Greenblatt. Dr. Greenblatt is a board-certified addiction medicine physician. He's been a faculty member at the University of Maryland School of Medicine since he completed his fellowship in addiction medicine in 2015. Now full-time, he divides his clinical responsibilities between the Division of Addiction, Research, and Treatment in the Department of Psychiatry and the Department of Family and Community Medicine. As the medical director of the UMMC Addiction Treatment Programs, Dr. Greenblatt treats patients, coordinates clinical care, hosts research projects, and participates in the clinical education of medical students, psychiatry residents, and addiction fellows. Dr. Greenblatt and his team are working to further the integration of medical and mental health services in the substance use disorder treatment setting. And finally, we have Dr. Neeraj Gandotra. Dr. Gandotra is the Chief Medical Officer for SAMHSA. Dr. Gandotra began his addiction career in public health by training within an underserved community in Washington, D.C., where he developed his perspective of how a nationwide approach to local addiction treatment is needed. Later, as the Medical Director of Addiction Treatment Services at Johns Hopkins, he directed and delivered care through the implementation of department initiatives and medical center resources. At Johns Hopkins, he also managed the administration and clinical treatment within an opioid treatment program multidisciplinary team setting. Immediately prior to joining SAMHSA, Dr. Gandotra served as the Chief Medical Officer for a large nationwide addiction treatment network, where he has developed national strategies specifically aimed at reducing risk, improving outcomes, and provider development. In addition to his clinical work, Dr. Gandotra is a member of the American Society of Addiction Medicine and American Academy of Addiction Psychiatry. Next slide. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. Next slide, please. I will now turn it to Dr. Neeraj Gandotra. Dr. Gandotra?
I have no disclosures to report, no conflicts of interest. And I also will speak for Dr. Olson and Dr. Greenblatt, who also do not have any disclosures or conflicts of interest reported. So thank you. Thank you all for attending. I'm going to give a little bit of background about SAMHSA for those of you who are not aware, and then go through a few introductory slides and background. The Substance Abuse Mental Health Services Administration is an agency within the U.S. Department of Health and Human Services, and we lead public health efforts to advance behavioral health within the nation. Congress established the Substance Abuse Mental Health Services Administration, SAMHSA, in 1992 to make substance use and mental disorder information, services, and research more accessible to the American population. It is SAMHSA's mission to lead public health and service delivery efforts by promoting mental health, preventing substance misuse, providing treatments and supports to foster recovery, while ensuring equitable access and better outcomes. We envision that people with, affected by, or at risk for mental health and substance use conditions receive care, achieve well-being, and thrive. Of note, previous slide, please. Of note, SAMHSA's Office of the Chief Medical Officer has embarked on efforts to expand and enhance our educational offerings. This includes creation of an educational committee to review the learning activities such as today, while we're seeking accreditations for such activities so that participants may eventually earn CME and CEU credits, educational credits for the activities they attend. I'm pleased to say that our application for accreditation is under review, and we hope that a successful review will yield more activities such as this, with the added bonus of being able to offer educational credits once we are accredited in the future. This activity is not yet eligible for educational credit as our application is still under review, but we are confident that there will be opportunities available later in the summer. We'll be conducting a survey at the end of this activity and issuing an attendance certificate for those who complete that short survey. Please consider completing the survey. We hope that the survey results will inform the educational committee on how we might improve our future educational efforts. I'd also like to thank our contractors for this activity, JBS International, who handles the logistics for this webinar, as well as our contracting officer, Michelle Gleason. I'd also like to specifically thank staff within OCMO, our Office of the Chief Medical Officer, and the Center for Substance Abuse Treatment, who have helped guide our educational curricula and the content here. These would include Robert Bilyeu, Amanda Dorson, and Jared Stokes. And finally, I'd like to thank Drs. Olson and Dr. Greenblatt for their generosity in agreeing to present this topic, which is an important aspect to the approach of whole person care. As you can see on this slide, we have pictured here our Assistant Secretary for Mental Health and Substance Use, Dr. Miriam Delphin-Rittman. And the Assistant Secretary is responsible for the managing and directing SAMHSA efforts. Under her leadership, we have many offices that advance our mission. Not all are listed here, but they include the Office of Behavioral Health Equity, the Office of the Chief Medical Officer, the Office of Financial Resources, the Office of Intergovernmental and Public Affairs, 988 and the Behavioral Health Crisis Coordinating Office, the Office of Recovery, the Office of Management, Technology and Operations, and our National Mental Health Substance Use and Policy Laboratory. In addition to that, SAMHSA has 4 flagship centers. These are the centers that guide service delivery and data collection. SAMHSA Center for Behavioral Health Statistics and Quality leads the federal government agency for behavioral health data and research. The Center for Mental Health Services leads our efforts to promote prevention and treatment of mental disorders. Congress created CMHS to bring new hope to adults and children who have serious mental illness or serious emotional disturbances. The mission of the Center for Substance Abuse Prevention is to improve behavioral health through evidence-based prevention approaches. And for our Center for Substance Abuse Treatment, the mission is to promote community-based substance use disorder treatment and recovery support services for individuals and families in every community. CSAT provides a national leadership to improve access, reduce barriers, promote high-quality, life-saving, and effective treatments, as well as recovery support services. Next slide, please. Here you can see our strategic plan, and this is available for viewing on our SAMHSA's webpage. The 2023 to 2026 strategic plan presents a new person-centered mission and vision, highlighting key guiding principles and presenting new priorities, goals, and objectives. To achieve our mission, we have identified 5 priority areas to better meet the behavioral health needs of individuals, communities, and service providers. The 5 priority areas are preventing substance use and overdose, enhancing access to suicide prevention and mental health services, promoting resilience and emotional health for children, youth, and families. The priority that we're addressing today, integrating behavioral and physical health care, and strengthening the behavioral health workforce. SAMHSA's work is guided by 4 principles that are integrated throughout the agency activities. These 4 principles are equity, trauma-informed approaches, recovery, commitment to data and evidence. Next slide. Here we can see SAMHSA's HHS overdose prevention strategy. The overdose prevention strategy expands the scope of the crisis response beyond opioids to include other substances that are often involved in overdoses. This new strategy promotes groundbreaking research and evidence-based informed methods to improve the health and safety of our communities. The strategy is guided by 4 principles: equity, data and evidence, coordination, collaboration, and integration, and reducing stigma. The strategic priorities are as follows: primary prevention, which focuses on the root causes and key predictors of substance use and substance use disorder, and how to safely manage pain. Harm reduction, which focuses on reducing risks associated with substance use, including those of overdose and infectious disease transmission. Evidence-based treatment, which focuses on providing the most effective evidence-based treatments without delay, reducing stigma and other barriers. And then, of course, recovery support. As lifelong interventions are required, this focuses on funding, reimbursement, training of workforces for, and developing protocols around peer, employment, and housing supports. Now, the successful implementation of this strategy depends on all of you, working together with federal, state, and local governments, hand in hand with healthcare professionals, law enforcement, policymakers, employers, advocacy groups, and the community at large. We really need to remove barriers so that we can achieve high-quality care. We have to invest in evidence-based public health and public safety activities. We must advance racial equity and equity for underserved populations so they can access health care. And specifically focus on treatment within the justice system, and revise drug policy. When we embrace the full range of interventions, including harm reduction, recovery support services, we fully realize the impact of such a strategy. Next slide. So a lot of focus has been in the past on integrating behavioral health into primary care. But this webinar highlights the integration can be bidirectional and models of which opiate treatment programs have been successful. OTP programs are often the first touch point for individuals with opioid use disorder as they re-enter the healthcare system. And quite often, when patients engage in treatment in OTPs, they'll engage in other treatment-seeking behaviors, other social capital building exercises as well. So as you can see from our learning objectives, participants should be able to, by the end of this presentation, describe the rationale for and the benefits for co-location of services. They'll be able to provide examples of service models that deliver integrated care within opioid treatment programs. And they'll be able to describe SAMHSA grant programs and policy levers to achieve this. With that, I turn it over to our distinguished speakers. Thank you.
Great. Thank you so much, Dr. Gandotra. And I think I am up first. I am just so thrilled and excited to be here with my friend and colleague, Dr. Greenblatt as well. So, but I'm going to start out. We have a lot of information to share with you all. This is an exciting area. I'm going to start off by kind of talking a little bit about some of the data that we have that describes the need for and rationale for integrated care. And then turn it to Dr. Greenblatt to talk more about some of the benefits that have also been described in the literature. So next slide, please. So this is data from the National Survey on Drug Use and Health, which is the largest national household survey that is managed by SAMHSA. And it looks at many different measures of substance use and mental health. I think one of the things that you can see on this slide, and one of the things that that NISDA really very clearly portrays for us, is that co-occurrence, that all ways that there are people who have substance use and mental health conditions, and that they are intimately linked. The data that you see here is from 2022 that shows you that both among youth, adolescents aged 12 to 17, as well as adults, that individuals who have either past year major depressive episode or other forms of mental illness often are very at high risk for substance use, whether that be illicit substance use, alcohol, nicotine, across the board. Next slide, please. And when we look at kind of the intersection in a different way on this slide, that really what you see is that there are millions of Americans, millions of people who have both substance use disorder as well as any mental illness on the far left of your screen, to also millions of Americans who may have more serious mental illness as well as past year substance use disorder. And again, that cuts across both adolescents, so ages 12 to 17, as well as in adults. So really, the bottom line is that these co-occurring disorders are very common, affecting millions of Americans every day. Next slide, please. We also know that people who have opiate use disorder, as well as other substance use disorders, often have other health problems as well. There have been many studies, but one study here from a very large health system found that, quote, after drug overdose and disorder, the leading cause of death among people with opiate use disorder really included cardiovascular disease, so things like hypertension and heart disease, cancer, and infectious disease, including HIV and hepatitis C. So the bottom line is that these are very common, that co-occurrence of substance use disorders, mental illness, and physical health conditions really are common and can have pretty devastating consequences for individuals. Next slide, please. But I think what is really important for us to know is that people who have those needs for integrated care to address these health problems, people who have opiate use disorder and these other common mental health and physical health problems, they may need that integrated care, yet programs like opioid treatment programs are rarely physically integrated with or located near primary care providers, which is where they may end up seeking care for those physical health conditions. So what do we do about that? And what are the benefits of integrated care? And for that, I'm going to turn to my colleague, Dr. Greenblatt.
Thanks, Dr. Olson. So as Dr. Olson mentioned, it seems that people who use drugs, people with opioid use disorder, and people who are engaging in care at opioid treatment programs could really benefit from having integrated care. I want to review some of the scientific data that underpins that assertion that actually this is a need, and hopefully demonstrate to you all that integrating primary care, infectious disease care, psychiatric care, and other care with opioid use disorder treatment can be really helpful for patients. And then a little bit later in the talk, I'll describe the way that we did it here at our site at University of Maryland. Because the takeaway, and hopefully we have some chance to talk about this at the end of the webinar as well, is every institution is going to, and every OTP is going to have to think about this in a way that works for your organization and for your patients. So hopefully by sharing a little bit of the rationale and sharing some of the lessons learned here at University of Maryland, that will facilitate other organizations building or refining the integrated care that you are providing. Next slide, please. So I have to admit, my slides jump around just a bit when it comes to the kinds of studies I'll be mentioning. Some of the studies mention the benefits of care that's integrated in an OTP. Although that hasn't been done that much thus far. So there's also a lot of slides about the benefit of providing opioid use disorder treatment in primary care settings, and also some information about the benefits of opioid use disorder treatment writ large. I will review that. There's some really interesting and nicely done studies, particularly in the primary care and infectious disease settings, showing that integrating opioid use disorder treatment and medical care is really helpful for folks. If you integrate buprenorphine treatment into HIV care, you can see that there is really significantly improved adherence to heart treatment and decreased viral load. That kind of corresponds with that improved adherence. That's from Akiyama's 2019 article. A really interesting study that was done at San Francisco General, where I spent a year before medical school, showed that actually, although the HIV clinic and the opioid treatment program were literally located in adjacent buildings on the SF General campus, sending someone to the next building over, sending someone who was engaged in opioid use disorder treatment at the OTP, sending them to the next building over actually resulted in worse HIV outcomes in terms of heart adherence and viral load compared to providing HIV care in that very same space. So really just a matter of a few floors and 20 feet was enough to make a difference in terms of HIV outcomes. Similarly, at a study that we did here at University of Maryland, if you provide hepatitis C care in an opioid treatment program, long story short, it works basically just as well as providing hepatitis C treatment to the population in general. As we know, DAA medications, hepatitis C medications, are highly effective, and they also work just fine for people that are engaged in treatment in an opioid treatment program. This should be no surprise. And then again, there's some evidence that integrating psychiatric care into primary care is helpful in terms of depressive symptoms. So, unfortunately, our medical system oftentimes is separated into individual subspecialties, and the truth is people tend to do better when they can get lots of different kinds of care in the same space. Next slide, please. This was actually a study that was done related to a practice across town, the comprehensive care practice, which is headed in part by one of Dr. Olson and my colleagues on the Maryland Addiction Consultation Service. So theirs is a primary care and infectious disease practice that also integrates opioid use disorder treatment. And what they found was that actually this resulted, the patients that got care in their comprehensive care practice actually did better in terms of retention in opioid use disorder treatment compared to other people that were receiving opioid use disorder treatment in non-integrated care sites. So this was opioid use disorder treatment integrated into a kind of a specialized primary care setting. But they found that folks who were getting care there did better in terms of their OUD outcomes, actually had fewer hospital stays in a 12-month follow-up period, and overall lower cost of care. So that's a study from Dr. Fingerhood and colleagues from 2019. Next slide, please. This other study actually, this study actually is the only one actually that I've been able to encounter that specifically studied primary care that is delivered in an opioid treatment program, which is ironic because that's what we're here to talk about today. But this is a study that looked at outcomes in a retrospective cohort analysis of patients that are taken care of in the Einstein Montefiore integrated programs. Kind of one of the first integrated programs that I'm aware of primary care being integrated into opioid treatment programs. Basically, the take home of this Gorovich study from 2007 is that linked care, getting primary care in an opioid treatment program, was associated with an increase in outpatient visits. No surprise, because people are getting the care that they need when they're going to an opioid treatment program, and a decrease in emergency department visits and hospitalizations. So increase in ambulatory care, decrease in emergency department visits and hospitalizations. This particular single site study didn't find any significant variance in overall healthcare costs, but the follow-up was I actually can't remember off the top of my head what the follow-up was for this study, but I'm sure there's a few other ways to slice it and dice it. And my suspicion is that ambulatory care is actually significantly less expensive than emergency department and inpatient hospitalization. So I certainly wouldn't be surprised to learn that similar interventions are going to result in decreased healthcare costs and expenses. Next slide, please. Kind of stepping back for a moment, I just want to remind everyone who's attending this talk that opioid use disorder in general is highly cost effective. And so making sure that people are connected to methadone treatment, specifically from this study, is highly beneficial in terms of overall cost impact in the healthcare system. Patients who received methadone pharmacotherapy for opioid use disorder used significantly fewer healthcare costs than fewer healthcare resources than those who were not receiving pharmacotherapy. And that's actually true for antagonist treatment as well, with extended release naltrexone treatment. Next slide, please. Making my own slides line up here on the screen. Sorry for the delay. And also, I think as probably many attendees here know, opioid use disorder treatment is really effective in terms of decreasing overdoses and death. So overdoses and death, overdoses are highly costly. Death is morbidly enough kind of not expensive for the healthcare system, but as healthcare professionals, we're all trying to avoid our patients dying. And so just encouraging those who have any questions, if there are any, about whether or not opioid use disorder pharmacotherapy is cost effective, to consult these studies. Next slide, please. Specifically, if we look at some of the cost effectiveness data, Methadone can decrease overdoses by 10% according to this, 22% with buprenorphine or naltrexone, combined with pharmacotherapy may be even more effective. Significant reductions in opioid overdose-related deaths with methadone, buprenorphine, naltrexone, and combo therapy, possibly a little higher than individually. And although we don't like to always think about our patients through the lens of being potential criminals, it's pretty significant to note that criminal justice involvement is also significantly decreased when an individual with an opioid use disorder has access to and uses medications for opioid use disorder. Next slide, please.
Okay. Well, so Dr. Greenblatt and I are going to really tag team here. So hopefully you now kind of are convinced that there's a need and there's a benefit for integrated care. Next slide, please. So now we're going to launch into some of the approaches to that integrated care. And when we think about this, there are really kind of three ways, and obviously there are multiple ways to think about this, but three of the ways that we commonly do is one that is really kind of care coordination, right? Where the coordination is driven by communication as its core. So screening and consultation, so things like screening and brief intervention, referral to treatment, hub and spoke models. Vermont was really one of the first that pioneered the hub and spoke model for the treatment of opioid use disorder with buprenorphine. But many models kind of where care coordination is really at its core. A co-location model is, and Dr. Greenblatt already mentioned this, that a co-location model kind of takes that, one step further. So not only is there care coordination, but really that the primary care or physical health conditions are being treated in a location that is proximal to where the substance use disorder treatment, and in our case, the opioid treatment program, is really located. And so here we're talking about care management, co-location, as well as care coordination and communication. And we know that there are examples out there. The collaborative care model that was recently also included as part of Center for Medicaid and Medicare Services reimbursement. Comprehensive primary care plus models are also an example of this. And these are often found commonly in federally qualified health centers that have integrated or co-located a whole host of different services into one location, kind of one physical site. On the farthest right-hand side, rather, now we're really kind of talking about true integrated care. And that's where care is truly transformed so that everyone is, you're working off of the same electronic health record, for example, working off of the same treatment plan for an individual. So health homes and system level integration is really the name of the game here. And there are some examples of this. Medicaid health homes, you're going to hear some more about some of the examples that Dr. Greenblatt will give you, where, you know, that co-location to integration, there's a lot of fluidity between those two models in particular, but a lot of it comes down to shared information, shared electronic health information, as well as some of the reimbursement and financial support that can make one easier than another. Next slide, please. So I'm going to punt it over to Dr. Greenblatt because
my cue. Thank you.
That's you.
Well, if there's a Simpsons reference, it's probably my cue. So I would just say, you know, as Dr. Olson highlighted, you know, there's this idea that we want to be able to provide integrated care and co-located care. And I have to admit, as someone who's been involved in some of the building processes of a practice like this, there have been times when I've wondered a little bit if we're building a Homermobile. So for those of you who are wise enough to not watch The Simpsons, as a reminder, there's a great episode from 1991 where Homer Simpson's newly discovered half-brother happens to be the head of an auto company, and he sets out to create the type of car, the car Americans really want, not the kind we tell them that they want. And long story short, they build this hopelessly impractical and expensive product because they throw in every single thing that Homer says is a good idea. I would say, I think these interventions that we are trying to integrate into our OTP and primary care models are more evidence-based than Homer Simpson's suggestions. So I can sleep easy knowing that I'm not building Homer-mobile, but I will say that it's not easy because the way that our system payment structure, licensure structure, training structure, specialties, what patients expect, the way that our urban fabric is put together, it really can be a challenging barrier. And so I do want to say, and Dr. Olson helped highlight this, I think, a little bit, is that you don't have to do everything all at once. Really taking some steps in the direction of integration, whether it's increased information sharing or increased referrals to resources, increased collaborative relationships as the new 42 CFR Part 8 recommendations, regulations mandate. I think that taking a step in the right direction is great, even if you don't get to build something that has every single bell and whistle in it. Because it makes sense for next slide, please.
Yeah, and that moves. It may be like you can take baby steps before you kind of get to the Cadillac. So take it away, Aaron.
Thank you. Thank you so much. Yeah, I mean, and the point is that it makes sense for our patients. I'm just feel so lucky here at University of Maryland. I can describe a little bit what we've done, but to be able to, as a provider in an opioid treatment program, be able to say to folks, actually ask why people's legs are all wrapped up. Mention that I'm able to cure their hepatitis C, starting with their initial opioid treatment program labs. Be able to integrate the medications that I'm prescribing as people's primary care doctors with methadone or buprenorphine dosing through our dosing window, using our excellent nurse care coordinators and health home nurses here to organize pill boxes and help with medication adherence, and also integrate syringe service programs into this setting so that we can create an environment of acceptance, collaboration, and kind of pragmatic treatment planning where patients can really have an opportunity to identify and pursue multiple health goals in this one setting. Next slide, please. So this graphic is from Partners in Health, which is an organization which I think, as many people here know, has done amazing work in Haiti and in Africa and in South America, I believe in Peru, building health systems that really benefit people who were traditionally disenfranchised and did not have access to meaningful Western health interventions. As they point out, they call it the 5 Ps. You need staff, stuff, space, systems, and social support. And really, it's not the focus of this talk exactly, but I will say that we needed to build, something starting to approach integrated care in our opioid treatment program. We really needed help on all 5 of these sides. We needed support from my departmental leadership. We got some private foundation support. We had support from the hospital in terms of supplies and our medical record. We had support from the hospital in terms of space. We had billing support. And so all of these things really do have to come together and Dr. Olson kind of at the end portion of the talk is going to talk about the ways in which these kind of braided support systems or funding streams can be helpful for organizations that are trying to figure out how to increase the amount of care integration. Next slide, please. This is genuinely a challenge for the system. It's at the beginning, we found that our hospital actually, in which the kind of opioid treatment program in this institution lives, was actually simply unable to bill for medical or psychiatric visits. This has changed a little bit, but there wasn't a whole lot of initial support directly from the hospital in terms of finances or logistical support. So long story short, we ended up having to build an entirely separate primary care, infectious disease, and psychiatric treatment structure, and that used the same space and the same electronic health record. Again, to highlight a point I made before, we weren't able on the first swing to actually end up with something that was truly integrated. Truly integrated, I can imagine, would be a single payer health system where primary care and a methadone program can all bill through the same system, operate in the same licensure. Everyone's trained enough in addiction medicine or addiction psychiatry to be able to kind of provide the full scope of services. But we did take, some steps in that direction. We were lucky enough to have, being in a university setting, we had some research funding to get initial medical care off the ground in the form of hepatitis C treatment. And then we had really this extra funding that came through a project called the Upper Payment Limit Supplemental Demonstration Project. Essentially, this is a Medicaid project that encourages innovation in healthcare systems by essentially giving higher payments, higher Medicaid payments to organizations that are meeting some self-defined goals. So in order to get access to this upper payment limit supplemental payments, we said that we are going to address emergency department utilization, inpatient utilization, and increase the amount of information we're collecting about our patients' social determinants of health. Since we can have the next slide, please. So this is the site where we're doing it. This is this interesting 22-sided building is the B&O Railroad Museum, the former roundhouse for the B&O Railroad. It's now an awesome museum. This thing with the big red asterisks is the site of our care. I think we used to repair railroad cars in this building. I never repaired a railroad car in my life, but that's what they did before it became a medical building. We have about 500 patients in our opioid treatment program, and about 60% of those patients now identify our co-located primary care practice as their primary care home. We also have visits in that co-located practice with other patients for walk-in care, even if they're not our primary care patients, wound care, psychiatry and psychology visits, as well as infectious disease visits. Remember that the outcomes that we kind of pledged to the state, to Medicaid, that we would address were emergency department and inpatient utilization, as well as increased engagement in terms of social determinants of health. And so it makes sense, if we're going to try to affect those outcomes, to really engage as broad a swath of our OTP population as possible, even if they don't yet, or if they're never going to identify this clinic as their primary care home. What else did I want to say about this slide? I will say that we looked at baseline data now quite a while ago in 2017. And long story short, as Dr. Olson highlighted in her first slides, patients that are engaged in opioid treatment program-based care have a lot of healthcare utilization at baseline. Lots of psychiatric comorbidity, lots of severe medical comorbidity, both acute and chronic, and acute superimposed on chronic. And so there was a lot of opportunity for improvement in terms of our patient health and well-being, and in terms of healthcare utilization. Next slide. So I could have put this slide somewhere else in the talk, but I would say that, as I mentioned, there's actually not that many examples of programs that have fully integrated or close to fully integrated primary care that is co-located with OTP-based care. The 2017 study that I mentioned kind of was specifically looking at the cohort of patients that get care through the Montefiore programs in New York City. That's a university-affiliated primary care program and integrated with OTPs. Similarly, there are a couple of other, one other academic affiliated integrated program. That's the App Foundation in New Haven, Connecticut, where people who go to this nonprofit foundation that operates as an opioid treatment program also, because it's a nonprofit, is eligible for grant funding and has a relationship with an academic organization. So they provide, as far as I understand it, non-billed primary care services within their opioid treatment program. So that's another approach. There are then, as far as I'm aware, 2 tribal health centers in Sequim, Washington, and in the Swinomish tribe and Connor, is it Connor, Washington, that have opportunities through tribal extra tribal funding streams that include casino revenue as well as Indian Health Service revenue to be able to provide integrated and co-located OTP and primary care and subspecialty care. And then perhaps the most generalizable model is the Mile Square Health Center model, where I was really grateful to be able to talk to their medical director in the fall. She was describing a model where, also saw her present at ATOD, describing a model where the medical care for the OTP, so all of the medical follow-up visits for their opioid treatment program, happens in a co-located federally qualified health center. So everyone who presents to that opioid treatment program is told that, well, we can accept every single insurance because this is a federally qualified health center. We'll see you regardless of your ability to pay. And if you're going to get care through our opioid treatment program, you'll be getting your medical care through this federally qualified health center. So everyone who goes to the FQHC is not necessarily on the OTP, but everyone who goes to the OTP gets their primary care through that federally qualified health center. And so lots of federally qualified health centers in this country, many of which are already providing opioid use disorder treatment with buprenorphine. Just want to say that shout out to Mile Square for developing what is an innovative and hopefully generalizable intervention. I will point out that federally qualified health centers also access from benefit from being able to access, as nonprofits, they're able to access grant funding. They're eligible for 340B revenue, and they're eligible for enhanced reimbursement because of their FQHC status. So what all of these integrated care models have in common is access to some additional braided support. Next slide, please. A word about our, I already mentioned that we have an integrated syringe service program here as well. I think I won't say too much about the genesis of our syringe service program, other than to say, similarly, it involved kind of baby steps. We started out with no syringe service program at all. I started out, I have to admit, with some trepidation, some difficulty myself kind of figuring out how a recovery-oriented or a treatment-focused opioid use disorder treatment program could somehow mesh with a harm reduction approach that acknowledges ongoing use and in some ways and supports people that are continuing to use drugs. I now realize that I was just totally wrong and totally kind of inflexible in my thinking, and that it's a totally natural fit because it gives us an opportunity, again, to accept patients, to recognize that they have a need and to help them meet their need, and really build relationships that can, over time, result in increased engagement and decreased medical comorbidities. The building process involved initially partnering with a local SSP before getting some additional funding through our health department and then through independent grant seeking to support our ongoing SSP efforts. We have a fixed model here. Next slide, please. That is to say, a model where we're not going out into the community. We encourage peer distribution, although that is a balance. That's to say, we don't expect that every syringe that someone takes is going to end up for their personal use only. We, like many SSPs, hope that people will share their clean supplies. Our goal is multidisciplinary distribution with community health workers, peers, nurses, physicians, and counselors, all involved in distribution of safer injection supplies. As of last fall, we had distributed over 500,000 syringes. Next slide, please. Lots of opportunities as sitting in an opioid treatment program with co-located primary care, infectious disease, and psychiatric care. Lots of opportunities to reach out into our community and actually into our host institution to try to make sure that patients who could benefit from our services have an opportunity to access them. This is where we get into the homermobile territory a little bit, because there's just so many opportunities, whether it has to do with other substance use disorder care providers in the community, our inpatient addiction consultation service, the emergency department, our drop-in center, which is a community kind of day room that we support here on site, and community partners. Lots of opportunities for outreach and internal marketing. The biggest challenge is just making sure that it all happens in concert. And I hope that other organizations can kind of learn from this and share best practices back with us and other folks. I think, next slide, please. I think I already mentioned all of this, but this slide just highlights the range of services that we have here at University of Maryland. So the idea is that in addition to our opioid use disorder treatment, we have all of these other services available for people who are currently engaged in or have once engaged in our opioid use disorder treatment. Next slide, please. I will say, I forgot to mention, and it's on a different slide here. I actually forgot to include in my slides entirely. The only thing I wanted to mention in terms of those outcomes that we promised our funders, the upper Medicaid upper payment limit, we promised avoidable emergency department visits, promised decreased preventable admissions, and increased social determinants of health screenings. Just want to highlight that actually compared to our baseline, by year 3, we had actually a 41% decrease in our avoidable emergency department visits. Our preventable admissions, believe it or not, were down 70%. Made us question it so much that we actually looked at our annualized year 4 data, and actually that 70% is probably it's maybe a data glitch. We seem to be a little bit flat or negative, but still avoidable ED visits were down 40%. And social determinants of health, we had increased screening from 4.5% at baseline to 50% screening at year 4. So people access the services, people get screened for social determinants of health. They don't use the emergency department as much, and they access our care. So just want to thank everyone for their attention and hand it back to Dr. Olson.
Great. Thank you so much, Aaron. And next slide, please. Yeah, so with that, hopefully folks are really inspired. I have to say, I get inspired every single time I listen to Aaron and just how he describes the amazing work that they've been able to do at the University of Maryland. And what's really exciting is that opportunity to kind of scale up, not necessarily his total model, but even just those little steps is what we have tried to put into the final rule of the 42 CFR Part 8, which is the rule that sets the standards for the provision of care in opioid treatment programs. It also, as you can see here, we updated certain provisions of that regulation, that rule, related to OTP accreditation, certification, and standards of treatment. One of the things that we very much did is really try to put in place flexibilities that help people then be able to go about their lives and really meet the goals that they have for themselves in their recovery. Expand access to care and treatment for opioid use disorder in opioid use disorders, and some other, and I'm going to talk a little bit later about some of the other changes that were made. That rule went into effect on April 2nd, so that means that that's the date upon which OTPs can start to take advantage of these rules. Understanding that there also may be state rules that they need to pay attention to, as well as accreditation standards, and the compliance date of October 2nd, 2024 is the date on which the expectation is that from a legal standpoint, OTPs need to come into compliance with these regulations. Next slide, please. And so there are some opportunities that we have really written into the rule for improved kind of that more integrated area of care. So for example, the final rule really promotes screening for mental health conditions upon entry into treatment. As you know, I pointed out, and as Dr. Greenblatt also reinforced, that so many of our of the patients who seek services in OTPs also are at high risk or have mental illness. And so screening for mental health conditions is really key. We've also included that initial and periodic medical examinations. People must be able to be have that offered to them and engage in that, really to assess their overall behavioral health, risk of harm, self-harm, risk of harm to others, and that psychosocial assessment it happens at the beginning as well as intermittently over the course of someone's care, is really the place and a time to ensure that information is gathered so that we can understand the context of that whole person's life, their mental health, housing, recovery support, harm reduction resources, all the things that Dr. Greenblatt talked about that are really important and that can be integrated into an OTP. Next slide, please. So now we're going to talk a little bit and shift a little away from OTPs, but kind of talk a little bit about some of the other things that are happening across federal government in terms of integrated care models, because OTPs is one example of where there is a lot of opportunity, but we have models that we can then turn to also learn from. So next slide, please. So I just wanted to mention that the Center for Medicare and Medicaid Innovation Center, so CMMI, that was also authorized through the Affordable Care Act really is part of CMS that has been tasked with creating, implementing, and evaluating novel healthcare payment frameworks, really with that goal of reducing or remediating concerns regarding increasing costs, quality, and ineffective spending. And as you have heard, that integrated care models, co-located care models, really are one of those models that can help us do that. Next slide, please. And in fact, you know, as Erin mentioned, there's been a lot of focus historically on integrating behavioral health into primary care services. Now, CMS and CMMI announced in January that really they are now starting to take a look at how can we actually use the behavioral health settings. So settings like opioid treatment programs and others, where people actually seek care for their behavioral health conditions, yet we know that they have so many unmet physical health needs as well. So how can we actually integrate then physical health care into that setting? So this innovation in behavioral health, or IBH model, is a new model that is really going to seek to bridge further that gap between behavioral and physical health. And that practice participants in this model will be able to screen and assess patients for select health conditions, particularly diabetes and hypertension, as well as mental health conditions, substance use disorders, in community-based behavioral health practices. This is a state-based model, and so it's going to be led by state Medicaid agencies. There are up to eight states that will be selected, and really with this goal of aligning payment between Medicaid and Medicare for integrated services. So this is just an incredibly exciting opportunity for states to and practices like opioid treatment programs to really be able to get into the game of not only looking at value-based payment models and getting geared up for that, as Dr. Greenblatt really, I think, spoke to, kind of one of the things that they're really working on in Maryland, but also then being able to shore up some electronic health records. There's some other pieces that also will be part of that model. And with a notice of funding opportunity that is going to be released hopefully shortly. Next slide, please. So if you want to learn more, if you go to the CMMI website, this is also what you will find on that website, which is an example of really how this model can benefit the individual with coordinated whole person care where really this Julia is getting all of her bipolar disorder, her opiate use disorder, high blood pressure, and diabetes addressed in the behavioral health setting with a lot of community support, so that attention to those social determinants of health, and this very close coordinated model of care where all of her health needs are being met. Next slide, please. So I also just wanted to highlight the Certified Community Behavioral Health Clinic, or CCBHC model. So this is a model that both has a component that SAMHSA helps to support through the CCBHC Planning, Development, and Implementation Grant, as well as a separate Improvement and Advancement Grant. And there is a Medicaid component to this model as well. So this is really where in clinics, these CCBHCs are supported financially for a range of integrated services for individuals with mental illness and substance use disorders. Next slide, please. And so as you can see here on this slide, that there are now over 500 CCBHCs across the country that are really supported through not only those planning grants or expansion grants, but also that Medicaid model. And in some cases, even states that have included their own funding to support this model. There are a set of 6 certification criteria that organizations need to meet in order to qualify as a CCBHC. And there are 9 core service areas that are either provided directly or through formal partnerships. So really kind of this integrated and or co-located care and coordinated care to provide that holistic set of services from all the way from primary care screening and monitoring, case management, screening, diagnosis, and risk assessment, psychiatric services, substance use disorder services, peer services, as well as crisis services, because we know that sometimes people really need and enter into care through that crisis situation. Next slide, please. And when SAMHSA has looked at its data for the CCBHCs that it supports through its grant programs, that we have found that across those 9 different sets of required services, that at 6 months, that people's use of illegal substances or binge drinking, people being hospitalized for mental health care or needing inpatient substance use disorder treatment, using the ER, or experiencing homelessness, all show a decline. Really, so, you know, adding this to the data that Dr. Greenblatt provided for the integrated OTPs, as well as some of the other data that we've already highlighted, I hope that you can really see that the benefits of integrated care are tremendous across a number of different outcomes. Next slide, please. So how do we, speaking of financing, how do we really kind of then try and help pay for some of these services? Because it's great to be able to set them up, but as you've heard, you know, really getting that payment and financial support is important. Next slide, please. So I'm going to kind of go through these rather quickly, because some of these are grant opportunities that some folks may understand or already know about. And then there are others that I would leave you to explore further to just understand how they might work for your organization. I did want to highlight the State Opioid Response Grant Program, which is a very large 1.6 or $1.5 billion grant program that SAMHSA provides to states, territories, and in one slide also there is the Tribal Opioid Response Grant Program that goes directly to tribal nations, really to address the overdose crisis, particularly the opioid overdose crisis, by providing resources to increase the access of FDA-approved medications for the treatment of opioid use disorders, including methadone, buprenorphine, injectable naltrexone, and for really supporting that whole continuum of prevention, harm reduction, treatment, and recovery support services for opioid use disorders and other concurrent substance use disorders. this has been really a tremendous resource, and SAMHSA just last week released its FY24 Notice of Funding Opportunity that you can find at the URL on the slide here as well. Next slide, please. And so I mentioned the Tribal Opioid Response Grant Program. So this is also similarly to the State Opioid Response Grant Program, supports tribal communities in particular to increase access to FDA-approved medications for the treatment of opioid use disorder, as well as that whole continuum of services that we know and have evidence for really helps to reduce overdose risk, overdose mortality, and helps support recovery and recovery supports. Next slide, please. That and by the way, that also the Notice of Funding Opportunity was just released last week for that for the TOR program as well. Quickly, the medication-assisted treatment prescription drug and opioid, or MAP-PDOA. This is a discretionary grant program that goes to community-based organizations primarily, and again, also similarly is helping to provide resources to expand and enhance access to MOUD, and so medications for opioid use disorder. So that really including individuals from diverse racial, ethnic, sexual, and gender minority communities, with the goal of decreasing illicit opioid use and prescription opioid misuse. In many of these grants, when you go and look at the Notice of Funding Opportunities, that there are a whole host of required and allowable activities that really span the spectrum of harm reduction, treatment, and recovery supports, which allows for really that integration of all of those different aspects and many of the different aspects that, that Dr. Greenblatt was speaking to. The MAP-PDOA program does not have a unique notice of funding or new notice of funding opportunity for FY24. But if you go on the URL, there is a forecast that SAMHSA puts out typically in August and updates periodically. And so I would encourage people to look at that if you're interested. Next slide, please. So OTPs is interesting. So SAMHSA doesn't have a specific grant program for opioid treatment programs, but we are very much involved in, aside from the regulations that I mentioned, 42 CFR Part 8, that we are very heavily involved in also working with the accreditation bodies that then accredit and SAMHSA certifies opioid treatment programs. And so we have information on our website about how organizations who are interested in becoming an OTP can meet the requirements, not only at their state level, but at the federal level, both for SAMHSA and the DEA as well. Next slide, please. And then speaking of kind of that continuum of harm reduction, treatment, and recovery support, so SAMHSA has to date had a dedicated harm reduction grant program. This was funded through the American Rescue Plan Act that was passed several years ago. It is now, this coming fall, will be starting the third and last year of this grant program. And it really was meant to support community-based overdose prevention programs, syringe service programs, and other harm reduction services in a very dedicated and focused way. We have across as many of our grant programs as we can within the Center for Substance Use Treatment, infused harm reduction approaches, services, and practices into many of our grant programs as either required or allowable activities. And so, again, really trying to support that whole integrated approach for individuals with opioid and other substance use disorders. Next slide, please. And, you know, Dr. Greenblatt mentioned braided funding, and braided funding, we understand, is really, in some ways, kind of the name of the game these days. That for organizations that want to do and are really interested in providing a whole set of services, that sometimes one grant program isn't going to be sufficient because it doesn't cover as many of the services that that an organization might want to provide to their population. So braided funding models really combine multiple funding sources to assist or support a single individual or a program. It has many benefits, as you've seen and as we mentioned, that it helps to optimize resources, fosters that sustainability, so you're not just dependent on one grant program, can help improve outcomes across a population because you can really meet the needs of a population, not only in one single condition, but across a whole set of conditions as well as social determinants of health. And it really helps to fill in some of those gaps in our services and systems. In February of this year, SAMHSA published a report on the use of braided funding for substance use disorder services. And so I would encourage folks to go and search our website for that report that is downloadable for free. And there was an accompanying webinar, the link of which also should be on that website. Next slide, please. And then I did want to talk just briefly about Medicaid because, Medicaid is often in many states really one of the main sources of funding for these types of integrated as well as individual discrete services. Sometimes there have been concerns about Medicaid and the types of providers that they will support through CMS. And that states are able to use Medicaid funding for. Just to highlight that in February of this year, HHS issued through CMS guidance that allows states to really expand the pool of behavioral health providers that are eligible for an enhanced federal Medicaid match for individuals who work at the state level with the state Medicaid program. That includes master's level and independently licensed marriage and family therapists, mental health counselors, including professional counselors. And so these are individuals who now can work with the state Medicaid program to really help and inform the design of an implementation of different types of models of care. So and funding for those models of care. So if there are any states that are listening, and have social workers or family therapists or licensed professionals working for them with their federal Medicaid programs, that really your ability to bring kind of that lens and that perspective and the experience that you have to bear on various different integrated care models is really an asset to all the different programs across the country. This guidance also allows for federal funds to support nurse advice lines as part of the continuum of care that is available for Medicaid beneficiaries, as that has been, there's been a gap in funding for that. Next slide, please. So those are some of the kind of grant opportunities and funding opportunities. There are many more on SAMHSA's website for grants. And I would also encourage folks to go and look at HRSA and CMS as other places also to identify potential funding sources for that braided model. But now let's talk a little bit more about some of the policy levers that we have in this particular space for opioid treatment programs. Next slide, please. So I'm not going to go through this in any great detail, but just to say that when we've actually looked back at the history of the use of methadone to treat opiate use disorder, if you think about this, this really actually has been kind of an integrated care model, even from the get-go, that the opioid dispensing clinics from the early 1900s, they often were primary care physicians that actually were using opioids to treat people's opiate use disorder at the time. All the way through to Dr. Marie Niswander, who as a psychiatrist really incorporated psychiatric services and psychiatric care in the patients that she was treating with methadone for opiate use disorder, kind of in that very early time of the emergence of methadone as a viable option for the treatment of opiate use disorder. And in the early 1970s, there was even more attention paid to methadone and how to really understand its use in the treatment of opiate use disorder, in addition to for people who also had many other health conditions. Next slide, please. And what we have obviously known over the years then is that the regulations that governed the use of methadone to treat opioid use disorder, that while they were established in the early 1970s, that they really have not changed very much since then. It was, kind of a system that was eventually, after a few years of Dr. Dole and Dr. Niswander and the early experience with methadone, that it became kind of a siloed system where people had to go very frequently, almost every day for some period of time, and that it wasn't necessarily really that integrated care model that we've heard about today until now. In early February, SAMHSA released the revised update to the 42 CFR Part 8 that we're hoping really will set the stage for much more of that integrated care, co-located care that we've been discussing. Next slide, please. And this has been a long time coming, and it may not have come without the kind of natural experiment of the COVID-19 pandemic. Because really what happened during that pandemic was that regulatory flexibilities had to be put in place to protect both OTP providers and patients. And so expanding those parameters of take-home methadone dosing, allowing for initiation of buprenorphine via telehealth, and recognizing that really this ongoing overdose crisis calls for person-centered, accessible care that really meets people where they are, and provides a number of those wraparound services and opportunities for people to engage in holistic, whole person care. Next slide, please. And so that is the hope with these changes, that really what will happen is enhancement of services and OTPs, improvement of that collaboration with partner services if this OTP cannot provide all the services themselves, but really facilitate access to life-saving medications, harm reduction, and recovery support services. Next slide, please. And so the underlying values and principles really within the revised rule are the ones that you see on this slide. And they really go across, from patient-centered care, kind of that shared practitioner-patient decision-making, having responsive, flexible OTP services that is evidence-based and uses non-stigmatizing language, and also understands that practitioners and their clinical judgment is part and parcel of kind of that shared practitioner and patient decision-making. So it's both the practitioner and the patient really making decisions, whether it's about the type of medication that is being provided, the types of services that the patient's going to engage in, the number of take-home doses that the person is receiving. All of this is really meant to foster that engagement and retention and the culture that Dr. Greenblatt really described very well, that as a model that is happening at the University of Maryland. Next slide, please. And so the final rule makes permanent those flexibilities for the provision of unsupervised doses of methadone, that audio-only initiation of buprenorphine, as I mentioned, really reframing it from a rule-based to a clinical judgment-based model, using a benefits and risk framework that we do for everything else in medicine. Making sure that patients understand safe transportation and storage of medication, but really, again, taking those lessons from the COVID-19 experience and putting that into longer term practice. Next slide, please. So some of that means that those responsive, flexible OTP services include making sure that people have access. So removing from admissions regulations a 1-year requirement for opioid use disorder for adults and 2 failed attempts at withdrawal for patients younger than 18. Expanding access, again, also through initiation of methadone using audiovisual technology. and incorporating that harm reduction and recovery principles that I mentioned, really by kind of removing the participation in counseling as a contingency for medication. So counseling is important, and other services are important, but not necessarily kind of making the provision of medication contingent on participation in specific counseling. And again, really making sure that individuals have the tools and the information that they need in order to help keep themselves safe as they work also on some of their short-term and long-term goals that may include recovery as well. Next slide, please. And so I think as we're getting towards the end here, I also just want to highlight that the rule also makes or acknowledges both the skills and training of nurse practitioners, physician assistants as qualified practitioners within the OTP to the extent that their scope of practice within their state allows for that. Also acknowledges that maybe it's not even just fixed sites. We can use medication and mobile units to help get services to individuals. And that sometimes it may be that people need kind of this interim treatment modality because access to more comprehensive services in the OTP isn't available at that moment. But we really want to make sure that people are getting access to medications and crisis services as they need it before getting access to the whole comprehensive set. And then also recognizing that there are other settings in which individuals with opioid use disorder who take methadone or who may need methadone come into contact with healthcare practitioners or others, so long-term care facilities, jails. So really being able to use those locations now as sites for either ongoing or initiation of methadone and buprenorphine treatment. Next slide, please. And so all of that taken together, that what we're really trying to achieve with these changes is cultural shifts, not only in how people are provided care, but also in the service delivery that they are provided in opioid treatment programs. And that really goes for the integrated care services as much as possible as well. Next slide, please. And so how are we promoting this? So this webinar is one example of that. We are really just thrilled, and I'm thrilled to be able to participate in this with you all. We also are in the process of revising the federal guidelines for opioid treatment programs and are continuing to hold webinars and meetings with many of our implementation partners, including our federal partners, state partners, OTPs themselves, and accreditation bodies. So with that, I will turn it over to Matthew for any questions.
Thank you, Dr. Olson, Dr. Greenblatt, and Dr. Gandoja for your presentation. At this time, we will begin the question and answer segment of the webinar. If you have not already done so, please submit your questions by using the Q&A feature located at the bottom center of your screen. Our first question: can you speak more to which circumstances are a better fit for IBH versus CCBH?
So I think that's a question related to the IBH model and the CCBHC models. So the IBH model, that's a little hard for me to say because that is, the IBH model is a CMS model that they will be coming out with a notice of funding opportunity for. So I guess what I would say is encourage folks to, and the person who asked the question, to go to the CMS website, and we may be able to provide the link to that website for the IBH model. Take a look at the information that is there. CCBHCs, I believe, are a potential kind of provider type that CMS might be looking at, but there are a few differences, and so would encourage folks to go to look at the IBH model, also to and when the notice of funding opportunity comes out, to really look at that carefully. As well as on the SAMHSA website, there is also information about the CCBHCs that may also be helpful. So yeah, so hopefully that's helpful.
Thank you, Dr. Olson. And thank you, Amanda, for dropping those helpful links in the chat. Our next question. What most excites you about the future regarding the role of opioid treatment programs in integrated care?
I'm going to take a stab at this with, hopefully people can hear me a little better this time. My apologies earlier. First things first, with regard to what excites us the most is the sky is the limit. It really is, the limitations are related to the scope and expertise of the providers, the funding opportunities that may be available, but the idea that there can be innovative practices, not just for management of healthcare conditions, but we've already seen dramatic changes when it comes to when OTPs take charge of certain things. We've seen it in the infectious disease space in particular. Those with substance use disorder have seen the lowest increase in infectious disease spread of HIV because of programs like syringe exchange or syringe support programs, excuse me, and the harm reduction that can be utilized in the infectious disease space has been well documented. I think that there's, when it comes to behavioral health conditions that can be co-managed, many co-occurring disorders of anxiety, our providers are well equipped to address those as well. And as expertise grows in terms of curriculum development in professional schools, so that people are more practicing providers, graduating providers are more likely to be able to handle more conditions. You know, it's not uncommon, and Dr. Olson, Dr. Greenblatt can probably attest to this, that, you know, they're very comfortable in refilling medications for high blood pressure, for cholesterol, for diabetes in a pinch. But the idea that this can be a hub for coordinated care, another place where patients can get better management, really does speak to the idea that they'll be able to potentially track those patients better and improve outcomes. So I'm thinking in terms of, you know, reduce morbidity for cardiovascular disease, for metabolic syndrome. These are things that you know, OTP providers probably can comfortably go into, but the sky's the limit. I'll sort of turn it over to them as well.
I guess I would add one other thing, which is that the newer regulations, both the changes in 42 CFR Part 2, which is the confidentiality regulations, and 42 CFR Part 8 that Dr. Olson just reviewed, I think, you know, are all aimed at decreasing the isolation and stigmatization of substance use disorder treatment within the healthcare system. And I think, from my perspective, the thing that excites me, and this is my opinion, but I think that isolation, the fact that you couldn't access substance use disorder treatment records without jumping through a huge number of hurdles, I think that really hindered coordination of care and perpetuated the stigma related to substance use disorder treatment. So I feel that better integration, you know, being more, the fact that OTPs can now be more open to the rest of the medical system in terms of coordination of care is exciting. And that methadone may even, you know, the access to methadone is going to be easier both within and without OTPs. I think that's exciting.
Mm-hmm. Yeah, I would just and I think I'm really excited because I know that there are models out there that we can build off of, and you know, and as Aaron mentioned earlier, that you know, we don't have to go from 0 to 60 all at once. You kind of, there are small steps, but every step kind of forward in that direction, I think, is a really positive one. So we've got lots and lots and lots of opportunities to do a lot.
All right, our next question. where can individuals go to learn more about the role of OTPs in integrated care?
That is a great question. And, I think there's going to be more and more coming out about this. I think, as I mentioned, we are revising the OTP guidelines. Anticipate that there will be some information there. I would also point people to the treatment improvement protocols from SAMHSA. Medications for opiate use disorder. There's some information there about what is possible and kind of hints at what is possible. I think the other, while we are revising the OTP guidelines, there is the 2015 opioid treatment program guidelines that also speaks to some extent about some of the integrated care opportunities that exist within OTPs. But stay tuned, lots more to come.
Thank you,
And I would also just say that, as Dr. Greenblatt mentioned, that there are some amazing folks around the country, and at various different conferences, they also are presenting. So the ATOD, American Association for the Treatment of Opioid Dependence Conference, is coming up in May. Dr. Greenblatt mentioned that conference. And so, checking out some of the conferences that addiction-related conferences, there are always people and always experts from across the country that are presenting on amazing work that they're doing in this space.
Okay, we are now at the conclusion of our webinar. Let's go to the next slide. Before we end today's call, just a couple of closing statements. First off, thank you to our presenters, Dr. Olson, Dr. Greenblatt, and Dr. Gandotra. Second off, thank you for all of those in the audience who took the time to be here this afternoon. All attendees will receive a link to complete a survey at the conclusion of today's webinar. The survey link will be sent via Zoom directly following this afternoon's session, and again 24 hours later. We ask each of you to take a few moments to complete the evaluation, as your feedback helps shape future webinars. With that said, thank you again for taking the time to be here, and we hope everyone has a great rest of your day. Thank you.